Thanks for joining today's webinar, focusing on digitally driven dentistry and using cone beam computed tomography and intraoral scanning acquisition to enhance our restorative workflows. My name is Adam, Content Marketing Specialist with Henry Schein, and I'll be your moderator for today's presentation. If at any point during the presentation you have questions, please type them into the questions section of your control panel, and we will be sure to cover them at the end of the webinar. Please make sure that your volume is up and any large computer applications are closed to ensure a smooth connection. This webinar is presented by Henry Schein Dental, and no CE credits are being offered for attending the presentation. Our speaker today is Sundeep Rawal. Dr. Sundeep is an internationally recognized expert in dentistry and has been a featured speaker at over 300 dental conferences throughout the world. Thank you, Dr. Sundeep, for being here today, and we look forward to your insightful presentation.
Well, good afternoon, everybody, or good morning, depending on your time zone. Thank you all very much for coming today and attending this webinar. I'm very excited to be talking to you guys today because, you know, this is a topic that's near and dear to me, this concept of digitally driven dentistry, and specifically when it comes to using CBCT technology, intraoral scanning, and how do we merge that information. I think we're in the midst of a paradigm shift in our mindsets in dentistry, going from an analog world to a digital world, but also understanding how the technologies we have today allow us to work in ways that we never thought possible. And they allow us to do things with our patient care that allow us to deliver good restorative outcomes to patients in ways that are easier, faster, take less time, cost us less money, and really translate into affordability for patients. It's a win for everybody. And really, when we talk about this, it all comes down to getting into the digital world. And all of that really stems from how do we get information into the digital world? And that's what we're going to talk about today. We're going to talk about the two main components of getting information into the digital world that I utilize on a daily basis. And that is CBCT technology and intraoral scanning, and how we acquire that information and take it into the digital world. So when we look at these concepts, I always like to start with an analogy. And if any of you have ever driven in a Tesla, you know that this car is more than just an automobile. It is a piece of technology that gets you from point A to point B. And that piece of technology really allows you to experience something much different than anything we've had in automation in automobile technology in the last 100 years. And you know, I love that experience when I'm in my Tesla and I'm driving, because I really feel like I'm more in an iPhone than I am in a car. But when we have this kind of experience and we bring it to dentistry, we really look at the two pieces of technology we're talking today about, which is cone beam CT or cone beam computerized tomography. It's really more than just a 3D radiograph. There was a time when we looked at 3D cone beam CT technology as an imaging source to allow us to diagnose in 3 dimensions. And that's very valid. It's a very valid point. It's a good way to look at things. But the reality is the data we get from a cone beam CT can be used more than just how we use conventional radiography, or in other words, to take measurements. What I really mean by this is if you're taking your CT scan today and you're measuring for, say, an implant, and you say that I've got 10 millimeters of vertical height from the crest of the ridge to the inferior alveolar canal, I can place an 8.5 millimeter long implant. You know, that is not full use of that information today. There's more that we can do with the data we get from cone beam CTs. And just like cone beam CTs, with optical impressioning or intraoral scanning, it's more than just an impression. It's more than just replacing alginate, because what we can do with that data is really remarkable. And what it really all comes down to is, how do we get into the digital world? How do we get into a world where we can gain efficiencies, save time, money, effort, and get more predictable outcomes for our patients. And when we look at this, the initial starting spot is the CBCT and optical impressioning. It's really what I consider today to be considered data acquisition. It's acquiring data in the digital world and then utilizing that data, putting it into software, putting it into programs, going into design or planning scenarios so that we're able to then use the data. And when we use the data, we can then go into manufacturing. We can look at how do we create definitive restorations, or how do we plan provisionalization, or how do we design the smile, how do we really diagnose and treatment plan, and then ultimately how do we go into manufacturing all throughout that digital workflow and being able to get predictable outcomes. So when we look at where we are today, I mean, this is some of the possibilities we have, especially when we look at something like a cone beam CT. Look at what we can do with that information today, where we can bring in things like our teeth and know exactly where the tooth position is with respect to bone, and then plan accordingly. In this case, you're looking at the planning of zygomatic implant placement with 4 conventional length implants in the anterior maxilla. This is very complex information and planning that we have today that is more than just taking a 3-dimensional radiograph and measuring 10 millimeters of length and 8 millimeters of width. This is using the data to the fullest, to being able to plan and then execute on that plan based off of a prosthetically driven design. And we have this for CBCT, we have this for intraoral scanning, where is it more than just replacing the alginate? And the answer to me today is absolutely, because now we can use that data. We can go in our softwares with intraoral impressioning or intraoral scanning and get more utility out of that information than just replacing an alginate or a PVS material. So when we look at this and where we are today, if you look at the data for optical impressioning or even CBCT, what's shocking to me and also very exciting at the same time is that we are still in the early stages of adoption in dentistry. We have had these technologies, both CBCT and intraoral scanning technologies, have been in dentistry for decades. For decades we've had it. Yet if you look at the penetration in the marketplace, you'll see that we're only at about 15% for iOS, for intraoral scanning, maybe a little bit more for CBCT utilization. And so for me, this is really, it's a little bit shocking in the sense that we've had it for 20 years and we're not all doing it, but it's also in many respects exciting, because the potential room for growth and the potential room for change in how we treat our patients is extraordinary. We're really at the brink of a sea change in dentistry, where in 5 years or so, all of us will be treating our patients in ways that are much different and much more in line with where we are with modern technology today. So when we look at these concepts like CBCT and intraoral scanning, we want to make sure that there's a baseline that we all understand, and that is really the science behind it. We want to make sure that everything that we do is steeped in evidence-based dentistry and that it works. And when we look at the literature, and let's take intraoral scanning to start with, when you look at the literature of optical impressioning, we know clearly that there are significant advantages to using iOS in dentistry. Number one, we eliminate the need for a physical master cast. It's an easier transfer of information. It's instant feedback. I can prep a tooth, I can look at the margins, I can measure my clearance, I can see exactly where I am, and if I'm not appropriate, I can modify the prep while the patient waits. I don't have to send something to the lab and have the lab technician call me and say, hey, you don't have enough clearance. It's a more efficient workflow because of things like instant feedback, because we are transferring data over the internet and not shipping things that take a few days here and there to get to the appropriate place. It's also potentially a more preferable patient experience. It takes less time, and is it more accurate? And when we look today, we know that digital impressioning for sure takes less time than analog impressioning. And that, this is good literature that supports this for the single tooth application. I would espouse that in today's world, and what I will show today, even when we're doing complex full arch natural tooth dentistry, digital impressioning allows us to be much quicker because we capture more information in one bout than we can with the analog approach. And certainly participants prefer digital scanning compared to intraoral material-based impressions, right? We have good data that show patient outcomes prefer absolutely intraoral scanning or optical impressioning. When we look at the accuracy, we can clearly demonstrate and show that if you look at the digital crowns that are made through optical impressioning, we get better marginal fits, or less discrepancy between or gap between the crown and the margin of the restoration, right? And it's been shown that we basically can get much more accuracy when it comes to the fabrication of restorations when the impression is taken through an intraoral scan. And intuitively, this makes sense to us because we know that in the material-based world, we are dealing with error. In the analog material-based world, there is inherent error in our protocols, meaning you make an impression. The material you use to make an impression has volumetric shrinkage or change. That is error. You go to pour that model up with and to make a master cast with stone, and the stone expands. That is another source of error. And so we get, just because of the limitations of the analog world, error built into our fabrication process. Whereas with optical impressioning, it's a digital scan, there is no volumetric distortion. We know that it's accurate. And if we design and create restorations in the complete digital world based off of that digital optical impression, we know that those crowns are very accurate, okay? And that there's no significant difference statistically in clinical fit between digitally made crowns and crowns made from a conventional material-based impression. So when we look at the accuracy, we know it's there, but what are the possibilities? And when we look at things like our goals, can we accomplish our goals based off of the utilization of this technology? And I always like to start with, this concept of what is my goal in dentistry, and this is my goal. But, gone are the days of us looking at things in black and white. Today, we look at things in black, white, and pink, or in color. And how do we get back to this goal of health when a patient presents to us? So this is my goal for my patients. First off, I have a happy, healthy patient. She loves her smile. She's a productive member of society. She's got a job. She's got a family. She goes out to a restaurant on a Friday night and says, hey, what do I feel like eating? She's healthy in the white, in other words, the hard tissues. She's healthy in the pink or the soft tissues. You say smile, her whole face lights up. She's got confidence. Now, you and I look at this and we say, heavens, there is a chip on the incisal edge of tooth number 9. There's a millimeter of recession in a bicuspid. There's rotations in the canines. There's asymmetries in the free gingival margins. We look at this and we pick the smile apart. There's 20 things wrong with it. But the reality is this patient is happy and healthy. The real question is, how do we get to this vision of health? How do we recreate nature or the illusion of nature when a patient presents to us like this? So here's a young girl that came into our practice. She had implants placed out of the state of Florida. She ended up in our office with the chief comment of, Doc, I'm ready to go. I've had my implants placed. Everything's integrated. I'm ready to go. Now, I was not involved with the diagnosis and treatment planning. And so we're coming in a little bit behind the 8 ball here. And when we looked at this, we said, okay, we're dealing with the maxillary aesthetic zone. It's the anterior portion of the mouth, the smile line. We need to do something because I know I'm not good enough to make an impression of these 2 implants, deliver definitive restorations, and know it's going to look good. I'm not that good. I need to take this in baby steps. I need to make an impression and provisionalize. I need to site develop the gingiva because remember, teeth don't erupt from the gingiva in perfect circles. And so once I site develop with a provisional, I can then take the case from provisional phase to definitive phase. But when I go to make the final impression, you start to notice a couple of things. First off, you see incisal ledge, incisal ledge, and this is facial to the incisal ledge, or very, very close to it. So now in my head, I'm thinking, I'm gonna either screw retain or cement retain these restorations on. Those are the only two ways we really retain restorations on dental implants. And in this case, I know that the patient isn't going to accept having a hole coming out the front of the tooth. So I know I'm going to be cement retaining these definitive restorations. But when I do my provisionalization, I always screw retain the provisionals, always. Because remember, we are trying to create an emergence profile, develop the soft tissue, the pink profile. And if I have to add or subtract or modify to my provisional to mold or move the tissue, it is so much easier to do that with a one-piece restoration versus a two-piece crown and abutment complex. So when I look at this, we deliver the two provisional restorations and the patient says to me, "Doc, thank you. Thank you. I'm so happy. I don't have to wear this removable flipper anymore. But Doc, I have a question. What are these two gray lines going down the middle of my teeth?" And I'm thinking, two gray lines, what is she talking about? And what she was referring to is because the white material was so thin, she could actually see shadowing of the titanium gray temporary cylinder through the white material. So now in my head, I'm thinking, okay, well, I'm going to be cement retaining these restorations, and I better use a white abutment. So in the wonderful world of CAD/CAM and digital dentistry that I've been living in for well over a decade, we just diagnosed and treatment planned 2 custom zirconia abutments with cement retained crowns, all ceramic crowns. Now, that's not anything new. We've been cementing crowns on zirconia abutments on dental implants since the 90s, okay? Nearly 30 years. But let's take a closer look. And when we look on radiograph, we start to notice a couple of things. First off, if you look at where the head of the implants are with respect to the adjacent CEJs, we know from our perio literature that the appropriate position should be ideally 3 to 4 millimeters apical to the adjacent CEJ. The literature actually supports that the head of the implant should be placed approximately 3 millimeters apical to the proposed zenith of the free gingival margin. But in a radiograph, we cannot see soft tissue, so we make an approximation that if you look at the adjacent CEJs, you measure 3 to 4 millimeters apically, that's where the head of the implant should be. When we look at these 2 implants, we notice that they are actually coronal to the adjacent CEJs. So maybe these implants were placed a little too shallow. And then we look at this closely and we see that these are actually 3.0 diameter dental implants. And a fun fact about 3.0 diameter dental implants, we don't make zirconia abutments for 3.0 diameter dental implants. Why? We all love zirconia. We know it's strong. But go back to your favorite class in first year dental school. Do you guys remember Biomaterials 101? What we're really saying is zirconia is a material that is tough under compression. You put a compressive force on the material, it performs very, very well. But it's a ceramic, which is brittle, which means if you take a coffee mug and you drop it on the ground, what happens? It shatters. So it doesn't perform very well under tension. So if I take a zirconia abutment and I make it thin, a narrow diameter because it's a 3.0 diameter dental implant, I put a hole through the middle of it for a screw and start banging on it sideways, function, they don't perform very well. They have a higher incidence of fracture. So we know industry-wide, it is not a good idea to make zirconia abutments for 3.0 diameter dental implants. So now I'm scratching my head. I need a white abutment. I can't use zirconia. What can we do? And in this wonderful world of CAD/CAM that I've been living in, the only thing my dental technician and I could come up with was to wax and cast 2 UCLA style abutments with a high noble alloy, stacked porcelain to create a custom porcelain emergence, a custom porcelain margin, and opaque the whole thing with porcelain. Let me say that in English. The price of 2 CAD/CAM abutments is X. The cost of the 2 UCLA style abutments is the same price. Then I had to pay for waxing, investing, burning out. You guys remember those terms? Slinging molten gold, platinum, palladium, stacking porcelain to create a custom emergence, custom margin, custom opaque. And before you know it, these two abutments are the most expensive abutments I've made in the last 10 years of clinical practice. And I lost money on the case. And if that wasn't bad enough, here's the clinical outcome. Now, when you look at this, you say, something doesn't look right. Something doesn't look right. The laterals are too short. And when we look at this and we see that the laterals are too short, we know it's because the implants were placed too shallow. Now, ladies and gentlemen, I want everyone to understand that this is 100% a therapeutic failure on day one. This is not successful therapy. This is a failure of therapy. Okay? We did not recreate nature. We did not recreate the illusion of nature. This is a therapeutic failure. Now, mind you, 2 perfectly integrated implants, 2 perfectly sound crowns, right? The color's fine. You know, we got good value, good aesthetics to the white, but the pink doesn't look good. The clinical crown length isn't good. Aesthetically, it is a compromise, and therefore it is, without a doubt, a therapeutic failure on day one. And when we look at this and we see where we're at and how we got to this point, the reality is it is because when you look at this, it's because the head of the implants were not placed in an appropriate position. And because of that, no matter what I do, I will never be able to design restorations that will be a therapeutic success. There will be some sort of compromise. So the real question is, how do we get the head of the implants where they need to go? And the answer in the world we live in today is very simple. It's cone beam, computerized tomography, and guided surgery, right? We need to take a CBCT, but as I mentioned at the beginning of this program, we can't just take the CBCT and measure 10 millimeters. We need to use that information, acquire the data, and use the data through some sort of guided protocol. Take a case like this, one of the hardest cases you'll ever do in dentistry, which is the replacement of a traumatically injured maxillary single central incisor with a dental implant. This kid was playing basketball. He got elbowed in the face, came to my office a few hours later. We decided to extract and graft just to create the ideal maximum amount of volume of hard and soft tissue for us to utilize. We didn't opt to place an immediate implant because we weren't sure the exact nature of the trauma, if there was more trauma to the dental alveolar complex or not. But now look at what we do. We plan in software. So we digitize the information. We digitize the intraoral scan with an iOS scanner. We digitize the bone with a CBCT scan, and then we merge it in software. And then based off of all of our fundamental knowledge and experience, we decide the ideal place for the dental implant. But we don't stop by saying we can place a 4.3 by 13 millimeter long implant in. We execute on the plan by creating a guide. And that allows the implant to go in the right spot. We let it integrate, we go through our site development, we go through provisionalization, and then ultimately we end up with this result. Now, this result was not because I'm very good at using acrylic or composite or zirconia or Emax or lithium disilicate. The reality is we got this result because the head of the implant was placed in an appropriate position up here to allow me the running room to create the emergence profile to support tissues appropriately. Now, when I talk about this, what is the accuracy of CBCT-based guided surgery? And the reality is the science has shown clearly over the years that we get amazing results when we go guided. Meaning, if we take CBCT information, and most importantly, we use that CBCT information, not just to measure a length and not just to measure a width, but to diagnose the accurate position of the implant, planned in software, and then execute on the plan by going guided, we're able to place the implant within 1/4 of a millimeter of vertical depth within a couple of degrees of angulation. Now, when we say go guided, Today, that could mean static resin-based guides. That can mean dynamic navigation with a camera-based system, or it can mean robotics. We have three main mechanisms of guided surgery today between the three. We do all three in my practice, and the reality is all three have similar results, where we can place implants bodily in a vertical to apical to coronal dimension, in a bodily lateral buccolingual mesiodistal position within a couple of tenths of a millimeter and within angulations of about 2 degrees, right? If you look at the accuracy, you look at the work of people like Castulis, you know that if you look at freehand versus pilot drill only versus fully guided, the science is clear. When we place implants through some sort of guided protocol, we statistically get better results than if you freehand it. As a matter of fact, even if you do a pilot drill guide, you get statistically better results than if you just freehand it. So taking the information from CBCT and using it through software is the key to implant success, both in bodily position and in angulation. And that allows us to do some really good things. That allows us to have some significant advantages with our treatment options. Remember, it's more than just the CBCT. It's using CBCT to be able to affect therapeutic outcomes in ways that are efficient and easy and allow us to do more for our patients. So when we have that accuracy, when we know the implant's going to go in within a couple of tenths of a millimeter, we can do some pretty amazing things. Like the case here where we're going to digitize the information. You can see where we've taken the CBCT, we are merging it in software with the intraoral scan. And based off that merger, we now have a surface scan that's very accurate of the hard and soft tissues. We have a bone scan, a CBCT, that tells us very accurately the volumetric area of bone to work with. And now we can make sophisticated decisions about where implants should be, right? And when we do that, we can take it a step further, because as we plan this case and we know that based off of this planning right here, the implant is going to go in within a couple of tenths of a millimeter, within a couple of degrees, we can do things like take this into design software to plan and fabricate a provisional. Now we're combining clinical visits. We're combining workflows to get greater efficiencies in our treatments. And we can do things like create ahead of time a screw retained provisional prosthesis that we'll be able to deliver at the time of surgery. So we go ahead and we can operate, we can extract the tooth. You see, based off of the extraction of the tooth, we're able to then place the implant. The implant goes in guided, which means we know it's going in very, very accurately. And then because it's going in very accurately, we can deliver a screw retained provisional at the time of surgery. You can see the 2-week post-op check, and we are maintaining tissues and being able to create or maintain that gingival architecture at the time of surgery. It's very powerful because it allows us the ability to create predictable outcomes for our patients, right? And that obviously works with the immediate extraction site where we're going to be maintaining gingival architecture. It can be for a native site where a patient has congenitally missing lateral incisors. And now we're going to follow this prescribed protocol to be able to deliver predictable outcomes. So here's a patient we follow with the intraoral scanner. We digitize the information. We do what we call a smile design. And then we do a motivational mock-up in the patient's mouth to really see exactly where she's going to ultimately end up. The patient approves of the mock-up, and now we have a blueprint where we're able to design based off of the proposed end result with the end in mind where that implant should go. As you can see, when we place this implant, we also are able to incorporate advanced restorative options like angulated screw channel technology, knowing we can place the implant in the most ideal situation here, even though the long axis of the implant has the screw access channel coming out the incisal edge, or very close to it, but we'll be able to angle correct here to create screw retain restorations. And then because the implants go in predictably, we get very good predictable outcomes. We have enough running room for our emergence profiles to be able to create the soft tissue contours we want. You can see from these provisionals just how thin the plastic material is, the acrylic, and that if I were to try and make this out of a ceramic material, there'd be no chance. But because we planned ahead of time to do angulated screw channel technology, which gives us the ability to move the screw access channel up to 25 degrees to go from a cement retained situation to a screw retained situation, we know we're able to deliver a predictable outcome to this patient and know that we're going to be able to deliver the aesthetics we want with the function we want, have total retrievability, and use innovative restorative protocols, all because we used intraoral scanning technology and we used CBCT. So we have tremendous benefits and efficiencies in the workflow with single tooth applications, but we also get tremendous benefits with full arch implant therapy, right? Or full arch natural tooth restorations for that matter. So when we have something like this, a terminal dentition, how are we going to be able to digitize information and take a patient from here predictably to this outcome? And this is where we utilize CBCT and iOS. And I truly believe that there is no greater treatment there's no treatment modality that's had greater benefit from utilizing CBCT and iOS technologies than full arch implant therapy. Full arch implant therapy used to be the hardest, most cumbersome, time-consuming, lengthy procedures we could do in dentistry. And therefore, they were the most expensive. Therefore, they were the least treatment modality that we were able to do because most patients couldn't afford to do it. But all that changed in the last 10 years, 15 years, because we're utilizing these technologies along with CAD/CAM and milling of things like titanium and zirconia to be able to deliver predictable full arch outcomes that are affordable and now today have become the easiest dentistry that I can do in my practice. So what we do is we have the ability to take patients, and guided therapy has been around in full arch implant dentistry for a long time, almost 15, 20 years now. And when you look at the science, remember again, we can place implants very accurately. And it was first launched in 2005 by Daniel Van Steenberg's group. They brought it to North America. And really what we were able to do is digitize information where we can see the bone, we can see the teeth, we can plan where the implants need to go, and then accurately place the implants based off that plan. How accurate are we? Again, within 1/4 of a millimeter, within a couple of degrees of angulation, so that we can place implants and get great restorative outcomes and know that we ahead of time are confident in implant placement. So I can take a patient like this today who comes in, who has a terminal dentition. Her teeth are failing. And what we're able to do is scan her. Now, these two teeth, if you look at 8 and 9, they're so mobile that if we were to actually make a physical impression, we would ultimately take out 8 or 9 in the impression. But instead, we're able to scan her, digitize the information, merge it with CBCT information to plan the case. But we take it a step further because she had some existing implants. So now when I digitize her intraoral scan, this is what I talked about with iOS and full arch being quicker than material-based or analog protocols, because look at the information I get in one scan. I can see clearly where my existing restorations are. I can see where clearly the head of the implants are with a very accurate soft tissue profile for the emergence. And I can put scan bodies on and know exactly the most accurate position of the head of those implants. So if I have all of that information in one scan, I can do things like create ahead of time a screw retained provisional. Now this is going to be a all-on-4 type prosthesis where we place maybe 1 or 2 more implants. We have existing implants. We do not need bone reduction, so we create here a tooth-only prosthesis, a white-only prosthesis, like a crown and bridge style restoration with abutments and ponics. We go to the day of surgery, we're going to able to take out the tooth, and based off of our CBCT and their surgical guide, place the implant very accurately, and then provisionalize the patient all in one day. You get very efficient in this full arch therapy because we're able to take all of that data from intraoral scanning, from CBCT technology, and we use that data. This becomes a very routine procedure that we are able to perform in our practice because we have some information in the digital world. And then post osseointegration, we have the ability to take this information and do amazing things, because now I can actually scan where the provisional prosthesis is. In the lower arch, I can scan the provisional prosthesis in the upper arch, and I can then do more with the data because I can take things like the bite. Once I have the bite, I'm able to then do things like articulate at the right vertical with the right centric, and then I can even cut away the provisional and then scan the soft tissue. I can put scan bodies on so I can get a fairly accurate representation of where my implants are. Now we know that full arch implant iOS is not 100% there yet, but we're close. We're close that I can capture all of this data, give it to my lab with one material-based impression only in this situation, and look at what we're able to do. When the lab technician has all of this information, now we're able to go and predictably create definitive restorations. In this case, we're going to take a patient who has a lower mandibular arch, implants are ready to restore. We scan, we digitize the lower prosthesis. We use our intraoral scanner, we scan the opposing dentition. And then once we have that information, we're able to take a bite registration. Now the technician has all of the information they need. And because we live in the world of CAD/CAM milling, the technician can go ahead and fabricate the definitive restoration. I don't need any try-ins. I don't need to do any other steps to make sure that teeth are set in wax appropriately. And we can then design, in this case, a milled acrylic restoration. This can be milled PMMA with veneered pink that we then take to zirconia if we're doing monolithic zirconia. This could be, in this case, a milled polychromatic monolithic acrylic that is a white and pink with an embedded titanium framework. This framework happens to be printed titanium. It is selective laser sintered printed titanium, additively manufactured, embedded in a puck. The puck is white and pink, and then everything gets milled in one shot to create, in this case, a milled polychromatic monolithic hybrid that allows me to deliver a very good result to the patient and go from final impression to delivery, or what I consider today data acquisition, which is scan the patient, scan the prosthesis, scan, articulate, get all that information in the digital world. So we do data acquisition to delivery in 2 visits. And that is why today full arch implant restorations have become the easiest restorations I do, because when it comes to do definitive therapy, I can go from data acquisition or final impression to delivery in 2 visits. I can't do that with a single maxillary central on a natural tooth, because when the patient comes in, I got to prep the tooth, make the impression, we make the crown, we come back, it's not totally perfect. I want to add a blue hue here, a white spot there, change a contour. It takes me a lot longer to do a single maxillary central incisor, match the shade, match the characterization, than it does to do a full arch of implants today. And that's the power of the technology, and that's where we are today with this wonderful technology. So let's take one last case, which is a clinical example, and this is where we tie it all together, where we're using CBCT, we're using intraoral scanning from diagnosis to delivery. Our patient comes in, she's got a worn dentition. We're going to be rehabilitating the maxillary mandibular arches. We started with the maxillary arch, and we start with a smile design. So we're going to acquire the data. The first thing I do is scan the patient. You can see she has some existing implants in the upper right maxillary, the posterior area. We're going to digitize the information. And once we digitize the information, we're going to take our CBCT, we're going to take our intraoral scan, we're going to take our photography or videography, And then we go into Smile Design software. We use facially driven dentistry here, where we look at what's going on with the patient from an extraoral perspective. And then based off of science, we know where the teeth should be, where the appropriate incisal ledge should be, where the midline should be, where the occlusal plane should be. And then we're able to design digitally our tooth position. And based off of that, we're then able to do our motivational mock-up. We can make any changes. In this case, we decided to shorten the teeth slightly. And then we're able to provisionalize and preparation of our teeth. We're now going to scan the implants along with the natural teeth. And look what we can do. I can, in one set of data, I can scan the provisionals and that the patient's been wearing, that's been testing the occlusion, the vertical dimension, the centric relation, aesthetics, phonetics, function, everything. We can take that, and then we can also, in the same file, cut out the preparation, the pre-preparation provisional scan, and then we scan in the preps of the natural teeth. We're able to scan in our scan bodies, and now all in one file, I'll be able to see where my preparations are. I'll be able to see where my implants are. I'll be able to take high definition pictures to show the dental technician where the margins are. And then I'm also able to have this against the opposing dentition with the provisionals. Now, if you have all of this information in one file, your technicians don't need anything else. There's no room for error for them, so they can take the case to finish. In this case, creating definitive all ceramic restorations. Those ceramic restorations can be lithium disilicate, they can be monolithic zirconia, they can be micro-layered zirconia, whatever your preference is. And then we can do things like, again, angulated screw channel technology in the posterior for the posterior restorations to ensure we get adequate circumferential thickness of zirconia. And we deliver these restorations. I take this a step further because now I have the ability to continue to digitize this information. We scan her, again, opposing dentition. We're going to scan her new maxillary arch with the new prosthetics in place. And we're able to then take that information with the occlusion and merge it with the CBCT. And now I have total control over placing the implant as we showed. So we went in this entire scheme of digital workflow from smile design to data acquisition to delivery of restoration to bring it back into where's the bone, fuse that with a new scan, new surface scan, because now I know exactly where the new restorations are going to be. And based off of that position of where the new restorations are, I can very accurately plan and predict where my implant needs to go. So you'll see that we merge the information. The information gets merged between the surface scan and the bone. And then we're able to, based off of that, plan an implant and plan it very accurately so that we place the implant within 1/4 millimeter of vertical depth or bodily position within a couple of degrees of angulation. And then based off of that, we remember it's not good enough to put a 10 millimeter long implant in. We've got to execute on that plan. So we can create a surgical guide, or we can take this into dynamic navigation, or we can take this into robotics, whatever our preference for guided surgery is. But we are not going to freehand the implant placement. And as you can see, it's very easy. In this case, we create a surgical guide. And now we know that the implant will go in predictably where we planned it to be. After that, you're ready for surgery. You can place the implant, and you know and trust that you're going to get good restorative outcomes because we utilized the entire digital workflow. We took intraoral scanning to get our initial data of what's going on inside the mouth with the hard and soft tissues. We took good CBCT technology to get our accurate representation of where the underlying bone is. We merged that and used that information throughout a complete digital workflow to get predictable outcomes and gain efficiencies. I was able to do this entire case in about 6 to 7 visits, not the normal 15 or 20 visits it would take me to do full maxillary rehabilitation, because we combine a lot of steps and able to do it efficiently. Because it's efficient, it's predictable, it takes me less time, there's less chair time, less expense. I can make it more affordable. And since I make it more affordable, the patient says yes to therapy. I want to thank everybody for taking the time to listen to us today. I hope you guys enjoyed it. If there are any questions, we will take the questions now.
All right, thank you, Dr. Sundeep. Very insightful. Our first question is, would you say robotics can help to properly place implants?
So we have
Yes.
in dentistry today, we have three main mechanisms of performing guided implant placement. Guided used to be the conventional thinking or wisdom is guided means you print a resin guide. What we call that today, when you print a resin guide, we call that static guided surgery, meaning it's one moment in time. You only have the ability to place the implant based off of the plan, okay? If you deviate from the plan, that static resin guide is useless. So we've had new innovations in the last few years. Well, navigation's been out a little bit longer, but we've had a new innovation that is not static in nature, it's dynamic, meaning you can change your plan intraoperatively and still place an implant through a guided protocol. With dynamic guided surgery, there are two main ways of doing it. Way one is called camera-based navigation, which is what you see with a system like XNav, where you have a real-time tracking of your handpiece that you can see in augmented reality, so that you can look at a screen, see where the handpiece and the drill is and the implant with respect to what's going on in the mouth in real time. You can know where you plan the implant, and you can place the implant based off of that in augmented reality. The benefits of camera-based navigation are you're able to place an implant, get the same results as static-based guided surgery, but it is dynamic, meaning if I change the plan, I can move the implant in the planning software and place the implant in the new modified position accurately intraoperatively at the time of surgery. The limitation of camera-based dynamic navigation is it is still freehand surgery. So if I see on my screen that I'm drilling to depth, I'm at depth, everything looks good, it's very accurate, and I sneeze, my hand moves. Whereas the next iteration is taking the best of dynamic navigation, the best of static-based resin-guided technology, and that is robotics today. And robotics, predominantly, the only FDA-cleared system in use today is the Yomi system from Neosis. And the Yomi system allows us to place an implant utilizing a robotically driven guidance, where your handpiece you're holding, it's robot-assisted dental surgery, where you're holding the handpiece, you're drilling, the back of the handpiece is attached to a robotic arm. Same premise as navigation, where you can see on a computer screen where your drill is, you can drill to depth. When you get to depth, though, the robotic arm locks and you can't drill deeper. And so you get what we call haptic feedback that stops you from moving. So it's a physical limiting step, such the same as static-based resin guides, with the ability to be dynamic and change the plan interoperatively with the similar as camera-based navigation. I hope that answers that question. It's a little bit of a long discussion, but that's a brief synopsis of what robotics and implant placement means today.
All right, our next question is, how do you decide on the wax up shapes and sizes before it's done, or are you allowing the lab to make that decision for you and the patient?
So there's several different ways you can do this. If you're doing a digital smile design, you can take the time to manipulate the software, and you can create the design of the quote unquote, let's call it digital wax up or virtual wax up. You can create the shape, size, everything yourself. You can rely on a dental technician to do that for you, and you can modify it. The key is when we do a digital smile design and we create that virtual wax up, I don't want to just blindly follow it. And that's why we always do that motivational mock-up, where we'll basically, based off the digital wax up or virtual mock-up, we'll print a 3D model, make a matrix, and we will do the mock-up in the patient's mouth to show them what the new tooth shape and form will be so that we get their approval ahead of time.
All right, how do you set up the scan for a patient requiring full upper and lower dentures supported by implants, more specifically with regards to capturing the preferred bite to restore final denture?
So I'm not exactly sure what you're asking, but what I'll tell you is this. When a patient is totally edentulous and they're wearing maxillary and mandibular complete dentures and you're setting them up for implant placement, most protocols today require you to do what we call a dual scan technique. You put some sort of fiducial marker on the denture, meaning gutta percha or Schur markers, what have you. You scan the patient wearing the dentures in the mouth, and then you scan the dentures by themselves. It's called a dual scan technique. Then the software allows you to merge those files. So you, as I showed you in the very first opening montage, you can see where the tooth position is with respect to the edentulous arch. The key to that is you have to have well-made dentures where the teeth are in the right position. Now, that brings up a good point that I'll bring up, which is you need to know where the teeth need to go, meaning you need to know how to make good, complete dentures. So everything we talk about, the technology, you have to remember, technology is a tool that allows us to do our jobs better, faster, more predictably, easier, get good outcomes, save money, time, effort, make it more affordable. But it's still a tool. It doesn't replace clinical experience. So I need to know how to make a good, well-fitting maxillary mandibular complete denture with the right tooth position, which those principles haven't changed, so that then I can input that data into the technology. I hope that answers the question.
We do have a couple more. The next one is, what benefits, if any, do you see in using a scanner and CBCT from the same manufacturer versus different manufacturers?
Yeah, that's a great question. Look, that brings up the whole discussion of open versus closed architecture. There are going to be systems out there where the scanner and CBCT machine function on a closed architecture circuit, meaning the software is more closed. It's not a totally open architecture. In those systems, and I mean the classic example of that is CEREC or Sharona. They work very, very well within their own architecture. The softwares are aligned, the parameters are all set up. It is a seamless integration. It is like me taking my Apple iPhone, watching a movie on it, plugging it into my MacBook Pro, driving home, going into my house and turning it on my Apple TV. Very seamless, very good, user-friendly, good integration. In those types of situations, you want to try and remain within the system. Now, there are other systems like 3Shape, which is what you saw me present on because I'm an exclusive 3Shape user, that are totally open architecture. In those situations, you can use any CBCT with my 3Shape Trio scanner, and you're going to get great results. The key is you need to make sure that you calibrate or you make sure your settings for your data acquisition are in sync with your software. So if I'm using Implant Studio from 3Shape, Implant Studio has parameters that the CBCT needs to be taken, the voxel size, the amperage, the exposure, all that kind of stuff. You need to make sure that you're taking it at the manufacturer's recommendations for the software you're using. So there's just a little bit of things that you need to look at and make sure. It's like getting, it's like playing a video game, and you want to make sure you get a laptop that has the appropriate graphics card. Just make sure that you do that, make sure it's the appropriate one, set up at the right specs, and you'll never have a problem. So if you're in a totally open architecture situation, just make sure that your settings are appropriate and you'll have no issues. If you are dealing with a closed architecture system, you want to kind of stay within the confines between CBCT and intraoral scanner.
That same person would also like to know if you recommend onboarding both scanner and CBCT simultaneously, or does one come before the other?
Yeah, that's a great question. I'm a big fan of onboarding in segments because oh, the companies in the industry that say, hey, listen, you don't have to think. You just buy my entire system and you go from A to B, B to C, C to D, and you'll never have to think about it and it'll do it all for you. And that is just not the case in dentistry. Um, if you don't know and understand how to use the technology, and more importantly, it is not well integrated in your practice with your team, with your assistants, and everybody around you, you'll never adopt it. The learning curve becomes too steep, and you ultimately end up not using the technology. And that's where we get bad user experiences. So I'm a big advocate of always starting out with baby steps. If I had to pick, I would always start with an intraoral scanner because I can start with data acquisition at the most basic level, which is natural tooth dentistry. I can start with doing things like inlays, onlays, crown preps. I could start with, obviously you can do full arch natural tooth restorations, but you can do, the very basics. You can do night guards. You can do orthodontic appliances, aligners. You can do all types of stuff and really integrate the intraoral scanner into your practice. Now, if you do a lot of surgery, you do a lot of implant placement, you do a lot of endo, then obviously diagnosing or ortho for that matter, diagnosing in 3 dimensions radiographically is important as well. And then I would incorporate the CBCT as well. So if you're already let's call it a moderately advanced practice where you're doing a lot of implant placement or a lot of aligner therapy or a lot of endodontics, then you're going to need the CBCT as well. But if you're just starting out, if I were building a practice from scratch and capital investments and expenditures were something I was sensitive about, I would certainly buy an intraoral scanner first, get that fully integrated into my practice, because you can always outsource your CBCTs. There's plenty of imaging centers in communities today. And then once I'm doing a lot of CBCT outsourcing, when I know I'm spending 3 to 5 to 10 patients a month, I would bring that CBCT piece in-house. And by the time you do that, you'll realize you're using CBCT on every single patient like we do.
All right, well, that will conclude our webinar for today. Thank you, Dr. Sundeep, for those great answers and for your presentation. And thank you everyone for attending today's webinar. We really appreciate your time and participation. If you have questions that we were unable to answer, or if you'd like to get in touch with the Henry Schein Equipment and Technology Specialist, please email us at webinars@henryschein.com. Everyone who attended today will be receiving a link to view the recording of today's presentation in the coming week via email. On behalf of Henry Schein, thank you, Dr. Sundeep, for an amazing webinar, and thanks so much once again to all of you for attending.
Thank you all very much. I hope you enjoy the rest of your day.